Can sinus CTs change antimicrobial management in febrile neutropenia, or are they low yield? I'm Francis Deng, a neuroradiologist at Johns Hopkins and AJNR podcast editor. Today, I'm glad to welcome my colleague at Hopkins, Rohini Nadgir. Dr. Nadgir is an associate professor and senior author of a recent AJNR publication on sinus CT in febrile neutropenia. Welcome, Ro.
Thank you so much for having me.
Let's start off with describing what is the clinical context that we're talking about here. What specifically is fever and neutropenia or febrile neutropenia or neutropenic fever?
So among patients who have hematologic malignancies and chronic hematologic conditions, they can be treated with chemotherapy and bone marrow transplant. But one of the important risks of this treatment is that they can become immunocompromised, and as a result, they become at risk for infection. And in this particular patient population, that can be very devastating with a high morbidity and mortality. So when we're talking about febrile neutropenia, we're talking about this particular patient cohort and trying to figure out the best way to manage the fever and minimize the risks of the potential infection.
And the way it's strictly defined is absolute neutrophil count less than 1,500 cells per ml and a body temperature greater than 100.4 Fahrenheit. And because these patients are at risk for morbidity and mortality, I imagine there's a lot of hand-wringing and diagnostic workup that these patients undergo. So my question for you is, what role does imaging play in the workup of febrile neutropenia in contemporary practice?
That's a great question. Well, generally speaking, when a patient in this condition presents with febrile neutropenia, the immediate steps are putting the patient on prophylactic antibiotics, broad spectrum, and the patient is placed on these antibiotics typically until their counts recover or a specific source of fever is identified, and in which case the antibiotics might be adjusted to accommodate for that potential source. The workup also will include a pretty extensive search for the source of infection, so blood cultures, urine cultures, nasal swabs, etc., looking at the skin for potential sites of infection, looking at lines and tubes, etc. The role of imaging, however, is a little bit more nebulous, and the literature is sort of not entirely clear on what specifically imaging is supposed to do in the setting. Ideally, we want to find the source of the infection as quickly as possible. And in some places, we end up doing imaging, at least CT chest and or CT sinus, to potentially identify the source so that we can treat quicker.
On CT sinus, I have to say it's one of my least favorite studies to read because so often the imaging findings are nonspecific. I find myself unable to come to a conclusion about whether there is clinically relevant sinusitis or not. So I'm really glad that you undertook this study. Why don't you describe kind of the design of your study and the patients that you included?
So we used our radiology information system to identify consecutive CT sinus studies that were done during a 3-month period with a clinical indication of febrile neutropenia. We ended up whittling down that number after looking through their medical records pretty intensively, specifically making sure that they were truly febrile and fit the definition of neutropenia. And once we gathered that cohort of patients, we looked at the specific imaging reports and determined whether or not the report was insinuating that the patient has acute sinusitis or doesn't, or it's stable or improving disease. And from that point forward, we examined the medical record for clinical notes from oncology, from ID, from ENT, to determine whether or not the sinuses were considered to be the source of infection and if any antimicrobial adjustments were made based on specifically the results of the sinus CT.
I want to clarify something about how you classified reports. So very often I would just report findings without making a conclusion when it comes to these, such as if there's mild scattered mucosal thickening in the paranasal sinuses. How would you classify those?
So it's very, very tricky, right? Because the imaging findings of sinusitis are very nonspecific. Really, sinusitis is a clinical diagnosis, and among immunocompetent people, imaging really doesn't have a role. So what are the findings of acute sinusitis? Well, some people talk about mucosal thickening and fluid levels, but the problem is that we can see these in all comers who come for imaging for other reasons, and they don't necessarily have acute sinusitis. So it's really tough to, make a determination of acute sinusitis, to be honest. And, I think it has to be taken into account the clinical condition. Does the patient have symptoms? Do they have rhinorrhea, headache, facial pain, etc.? And then, taking all those things into account, if you do see profound mucosal thickening, fluid levels, and a strong clinical suspicion, then you could say that the findings here support the clinical impression of acute sinusitis. And so when we reviewed the reports, we tried to make our judgment as to whether or not there was a finding of acute sinusitis based on that verbiage as best we could.
Got it. And so the patients you included spanned all different types of hematologic malignancies, basically leukemias, lymphomas, myeloma, and other conditions. And they were undergoing treatment, and that resulted in neutropenia. I think that's a pretty typical spread for what other centers may see in terms of febrile neutropenia. What did you find? What are your major results in your study?
So we had a bit over 100 scans that we looked at their reports and the electronic medical record associated with those scans. And we found that the majority of CT sinus studies were negative for acute sinus inflammation, and a smaller proportion were quote unquote positive. Among those positive cases, only a small subset of them had actual clinical symptoms of acute sinusitis.
Got it. So I want to walk through table 2 a little bit here. So it looks like that you guys had 127 CTs, and of these, only 4 had clinical symptoms of sinusitis, and all of these had a positive CT scan result.
More importantly, I think the major take-home observation was that regardless of whether the CT scan was positive or negative for sinusitis, there was no change in the antimicrobial management regardless. So patients were maintained on their antimicrobial regimen, or treatment was adjusted based on other clinical parameters, but it wasn't ever the imaging result itself that informed the change in antimicrobial management.
ENT consultation was performed in a couple of cases, but none of them found aggressive sinonasal infections. Can you expand a little bit more by what is meant by that?
So the biggest fear is that of aggressive fungal invasive sinusitis in particular, which has very devastating clinical outcome. And that's not a diagnosis we want to miss. That's one that we want to catch as early as possible to decrease the likelihood of that outcome. And so that's sort of, I think, the main crux of why we image in the first place, is to sort of try to find those particular patients. And it turns out, at least in this cohort, that there were no patients that had imaging or clinical or ENT findings that were concerning for an aggressive invasive fungal sinusitis type of picture. And of course, we are looking at a 3-month time point. And so certainly if we had evaluated more patients over a longer period of time, perhaps we would have captured a case or two of invasive fungal sinusitis. And that certainly is a limitation of our study. But the fact of the matter is that invasive fungal sinusitis is extremely rare, thankfully. And so who knows, if we had done an additional 3 months of investigation, we may not have caught another case of invasive fungal sinusitis either.
Certainly, you're not saying that invasive fungal sinusitis doesn't exist. It's just that it's extremely rare, and that a screening regimen that puts everyone through sinus CT if they have febrile neutropenia is very rarely going to incidentally catch someone who has invasive fungal sinusitis who had no other clinical signs or indication to get CT imaging. I want to go through a couple of exemplary cases that you had in your figure and just allow you to comment on what you think is practical to highlight from these cases. Figure part A was a 69-year-old with multiple myeloma who presented with nasal congestion, facial pain, and postnasal drip, so clinical symptoms of sinusitis. And on CT imaging, they had moderate mucosal thickening and fluid in the maxillary sinuses that was reported as consistent with acute sinus inflammation given the clinical context. So their antibiotics were changed a little bit later after the sinus CT because they had persistent facial pain, and ENT consult was obtained, which did not have any evidence of invasive fungal sinusitis. What stands out to you about this case, Ro?
So this is a typical clinical scenario that we come across where there's this mucosal thickening and the fluid levels, and what does it mean? And in this particular case, because the patient has symptoms of sinusitis, we can feel a little bit more comfortable saying that probably the findings we're seeing are indicative of acute sinusitis. But importantly, there were no aggressive, destructive changes. The nasal mucosa looked intact and the bone integrity was preserved. So we weren't thinking along the lines of an aggressive sinonasal infection here, but this could certainly support a picture of acute sinusitis. And again, I think that the diagnosis is clinically apparent even before imaging is done, and antibiotics were adjusted. But again, the emphasis here is on the fact that it was the symptoms, the facial pain that progressed, that prompted the change in antibiotics. It was not the findings on the imaging study itself.
Got it. So we have to rely a little bit on our clinical colleagues to connect the dots in terms of their clinical symptoms as to what is establishing the diagnosis of acute sinusitis, right? Figure Part B is an 11-year-old with acute myeloid leukemia who did not have any symptoms of sinusitis. And on CT, they had clear paranasal sinuses, and that was read as negative for acute sinusitis. There was no change in antibiotics, and there was no ENT consult.
Yeah, so this is a pretty straightforward case of clear sinuses, no symptoms, and so there was no change in antibiotics and no reason to consult ENT to scope the patient.
So I think it goes without saying that sinus CT probably has a good negative predictive value. If you have entirely clear sinuses, then you can pretty confidently say that there's not sinusitis, right?
Yes, I guess I would say that.
Part C is a 57-year-old with acute myeloid leukemia who did not have any symptoms of clinical sinusitis. They, on CT, had moderate mucosal thickening and fluid in the maxillary sinuses that were increased compared to a recent prior study, and so this was reported as concerning for acute sinusitis. There are also findings of left maxillary sinus wall osteitis, indicating chronic inflammation. Notably, this patient was intubated at the time of CT scanning, and no change in antibiotics was made. And ENT was consulted, but they did not find any evidence of invasive fungal sinusitis.
Right. So this image looks very similar to the first image that we talked about, and yet this doesn't look like a clinical picture of acute sinusitis, primarily because the patient didn't have symptoms. And yet we have the mucosal thickening, we have the fluid levels, which potentially could be attributed to the intubation. Very often we will see sterile effusions in patients who are intubated, which just goes to show how nonspecific the finding of fluid level is. So in this particular case, there was no change in antibiotics, there was no overt clinical suspicion, but nevertheless, ENT consultation also confirmed the absence of aggressive infection here.
Right. I very often make the observation that there's some sinonasal opacification or fluid in the nasopharynx, even mastoid effusions in a patient who does not have any clinical issues because they're intubated. So you can have pulled up secretions and sterile effusions in these usually aerated spaces in that setting, right? Our final panel is figure part D, 61-year-old with myeloid sarcoma who did not have any clinical symptoms of sinusitis. On CT, there was minimal mucosal thickening in the left maxillary sinus that was reported as nonspecific and essentially negative for acute sinusitis. There's no change in antibiotics. ENT was consulted nevertheless because of that mucosal thickening, but they found no evidence of invasive fungal sinusitis. An alternative cause of fever was found after blood cultures returned with Pseudomonas aeruginosa, and that was suspected to have come from their indwelling central line, which was removed.
Yes, so this case was particularly striking to me because I found the mucosal thickening to be particularly unimpressive and underwhelming, and yet it was that specific line in the report that prompted ENT consultation, despite the fact that the patient didn't have symptoms. And interestingly and reassuringly, that evaluation was unrevealing, and there was an alternative source of fever identified.
Do you have any practical tips on how we should approach reporting studies like these, which are very common in my experience, to raise the appropriate suspicion or lack of suspicion, as well as encouragement for clinical correlation?
Yeah. So my language has evolved over the years, particularly in light of this investigation. So I focus on what the primary concern is, which in my assessment is that of an aggressive sinonasal inflammatory process. So is there concern for invasive fungal sinusitis? And my impression will relay as much. I'll say There is non-specific mucosal thickening. However, there is no evidence of an acute aggressive sinonasal inflammatory process. So hoping to emphasize that there is some stuff going on. We don't really know what it is. It's probably unimportant, but reassuringly, there's no evidence that something more sinister is going on.
Right. So the aggressive features we want to look for are bone invasion, soft tissue infiltration outside the sinuses. Anything else?
Yes, certainly mucosal ulceration, particularly in the nasal cavity, nasal septal destruction, extension into the extrasinus compartments, pterygopalatine fossa, and then potentially even intracranially or into the orbits. Any of those kinds of findings is an absolute must to raise a red flag and even call the clinical team and let them know that you're very concerned about an aggressive sinonasal infection.
Terrific. So I want to give you the last word here. What should listeners take away from your article, and why should they read your article?
Well, I think this emphasizes the fact of what we know, that CT sinus imaging is not terribly specific, and it rarely will render a clear diagnosis of acute sinusitis or absence of acute sinusitis. It does have an important role when we're worried about an aggressive sinonasal inflammatory process, and that's the main clinical question. Is there concern such that aggressive change in management needs to be made? I do recognize that this is a very vulnerable population, right? These are not your average person off the street. They're immunocompromised. And so we need to sort of take a step back and try to understand what's appropriate imaging for these patients. And it's certainly still a matter of discourse, I think, between us as radiologists and our clinical colleagues as to where you draw the line, what's appropriate imaging and what's over imaging. And I look forward to those future discussions. But for the time being, I feel like this survey suggests that a routine sinus CT surveillance imaging probably is not going to be terribly helpful in general.
Wonderful. And I hope your study contributes to any future evidence-based guidelines that may come out in this sphere about recommending sinus CT in patients with fever and neutropenia. Thanks so much, Ro, for joining me this morning.
It's my pleasure. Thank you.
And for our listeners, you can catch the full article on the AJNR website out in the October issue. Until next time.